If you are deficient in any vitamins or nutrients, that's causing shedding or, making your hair small and not optimized.
Where do you take the hair from for eyebrow transplant?
Our hair tends to be a lot drier. The Minoxidil over the counter is in propylene glycol or propanediol.
The whole concept of hair transplants is that you're taking from an immune privileged site.
We come up with these very fancy regimens that we give to patients.
And it's really important to understand, not all hair loss is just you're getting older. And
I know.
And I think some people want to hear that. It's just like a regular common run-of-the-mill hair loss.
CCCA I consider to be like an autoimmune, autoinflammatory condition. We don't know exactly what causes it. It's multifactorial.
I'm Dr. Anthony Rossi, and this is Give Good Face, a podcast focusing on skincare science, and how to maintain and shape a healthy lifestyle. All right, everyone, welcome back to Give Good Face. And today is a really special podcast episode because I have Dr. Achiamah Osei-Tutu on. She's not only my friend, but she was my professor in residency.
Oh my God.
And you're giving very professorial, vibes right now, which I love. She's a world-renowned hair transplant surgeon and just an overall amazing human being. So I would love to talk to you all about hair today.
Amazing. I can't wait.
Yeah.
So thank you for inviting me to speak.
Of course.
I miss you so much.
I miss you too. It's the only way we get to see each other.
Exactly.
Because Achiamah's been all around the world lately. I've been following you on Instagram, and she's been traveling the world, teaching, and I'm sure learning a lot as well, right?
Yeah. Best way to also gather up information and steal people's things in their brains to bring back to patients at home. Yeah.
So when your doctors go away on conferences or trips, it's not just for fun and play.
No. There's rarely time for that.
Yeah. It's more of an exchange of ideas. We're learning, we're teaching our techniques. And I feel like for hair, especially, as dermatologists, we do learn all about hair, skin, and nail disorders. But hair transplant specifically is an art form. I mean,
it's such an exciting time, I think, to be a hair surgeon with both surgical and non-surgical hair restoration techniques. There's so much on the pike. We're constantly changing and evolving and perfecting the way that we do hair transplants so it looks more natural. I love going to conferences, workshops, and, learning all this stuff.
Yeah. We've come a super long way, especially with textured hair, right?
Yes, absolutely.
Yeah. My family are hairdressers, and I would see a lot of hair transplants walk through the door.
Hair that you always have.
Yeah, thanks. Not transplanted.
No.
No, but we've seen the whole evolution from these plugs now to more follicular units.
Yes.
And you deal with some pretty tough cases because you're doing a lot of scarring alopecia.
Yes, that's probably the thing that I do the most.
Okay.
Yeah.
Which is the hardest.
I get it. It is very challenging, but fun.
So tell us a little bit about, we know there's female pattern alopecia. Sure. We know there's male pattern baldness or male pattern alopecia.
Sure.
What's scarring alopecia?
So the important thing to note is when we break down hair loss, right? We break them down into scarring and then non-scarring. So with scarring alopecia, the hair follicle is completely and irreversibly destroyed, unfortunately. And it happens usually due to some sort of inflammatory process. And when we break that down, it's broken down into this immune cell type that's attacking the follicle. So they're lymphocytes, they're neutrophils, they're mixed, and then non-specific. And the one that I see mostly in the office is the lymphocytic type. So we're seeing centrifugal cicatricial alopecia or CCCA. That's the one that we see most often in women of African descent. And interestingly, a lot in men of African descent.
Oh, that's interesting.
Yeah. I think, when we're dealing with hair transplantation in patients of African descent, it's really important for them to have a biopsy.
Yeah.
For them to be diagnosed by a dermatologist. Turkey's a very popular topic these days.
It's a great destination for fun.
Exactly. I'm not a hater. They need to do whatever they need to do. You can be transplanting on inflammatory scalp disease. And if it goes untreated, the grafts are going to fail. You would have wasted your trip.
Yeah.
So we have CCCA. We have something called lichen planopilaris, which is really itchy, very bothersome to the patient. We have frontal fibrosing alopecia, which in Black patients looks like traction alopecia, where the hairline is moved backwards. So those are the main types that we see. And then we have lupus and other things, but that's the main type that we see in clinic.
Yeah. So, it's really important to understand, not all hair loss is just, you're getting older. And
I know.
And I think some people want to hear that. It's just a regular common run-of-the-mill hair loss.
Right.
Because that's almost easier to treat.
That's right.
You know, but with these inflammatory hair disorders, you really have to get to the root issue.
Absolutely. And
no pun intended.
No pun intended.
Yeah.
And oftentimes, like, it's not just one diagnosis, right? They have CCCA, they have traction alopecia, they have hormonal hair loss, the hair loss that you get when they're older. So we're seeing lots of things happening at the same time. And you need to make sure that you're addressing all those issues to optimize how the hair is going to grow. That's
amazing. So with CCCA and traction, there's like different insiders, right? Like traction is just pulling your hair back tight.
So, so exactly like you said. So traction is just due to extended hairstyles that your scalp doesn't necessarily like. You know, the braids, the weaves, even wigs that can rub up against the frontal hairline. And CCCA I consider to be like an autoimmune, autoinflammatory condition. We don't know exactly what causes it. It's multifactorial. You have your genetics, you have your hairstyling. There's been some research on, you know, different organisms that live on the scalp that may be at an increased amount in patients with CCCA. There's some metabolic dysregulation. So there's a lot that's going on, right? And of course, different hairstyles can make it worse.
You know, I always try to tell patients, like, if you're really concerned about hair loss, you should make like one separate appointment just for hair loss. Yeah. If a dermatologist had to tell you one thing, it would be like, make a separate appointment for hair loss.
100% hair loss is a lot.
Because there really is like a whole battery of exams, a litany of tests that we could do to get to the reason why you're losing hair.
And I think, you know, we can also use it as an opportunity to just make sure that they're taking care of the rest of their health, right?
Yeah, totally.
So if you are deficient in any vitamins or nutrients, you know, that's causing shedding or, you know, making your hair small and not optimized, we check labs. We make sure that you're following up with your primary doctor to make sure that everything is in good order so that your hairs can grow in a great environment.
This episode of Give Good Face is brought to you by Dr. Rossi DermMD, because great skin isn't just a luxury, it's a necessity. My team and I are redefining skincare with science-backed treatments, customized solutions, and a no-nonsense approach to achieving that effortless glow. Whether you're looking for cutting-edge dermatological care, the latest in injectables, or ultimate skin rejuvenation treatments, Rossi DermMD delivers results that speak for themselves. Because when your skin looks good, you feel unstoppable. Check out our skincare line at Rossi DermMD and use the discount code GiveGoodFace. Also, send me a DM if you like the podcast and just mention Give Good Face. Laundry list of tests that I run for hair loss is longer than
any
a skin cancer.
Yeah. Any other thing. Yeah.
So like we found thyroid disorders, right? Vitamin deficiencies.
That's right.
Lupus. Yeah.
Yes. Yeah.
So like an autoimmune condition. Sometimes you don't find anything.
A lot of times you don't find anything, right? But it's good just to double check. Yeah.
And then in those patients that you don't find anything, what do you like take a deep dive into like their daily practices?
Oh, I talk about everything.
Yeah, it's like a psychosocial.
Yeah, exactly. Who are you as a person? You know, we come up with these very fancy regimens that we give to patients. Like, are you even going to take it?
Yeah, that's
right. Like, what is your general ethos in life? Like, are you a no medication person? Do I need to walk you slowly towards taking medication? Do I go through a more holistic approach with you? If I give you a vitamin, you're going to take it? Do I start you off with the most important meds? So I need to find out who the person is and then work them up. Or if they're willing to take everything, then we do everything. And then we discuss what are all the non-surgical things that we can do depending on their degree of hair loss, right? And then if they need transplants, like, can I do it now or do I wait for it? And then also, what is stressing you out?
Yeah.
Right? If you have a lot of stress going on in your life, are you even going to prioritize the medications that I give you? So every single detail of that person's life is important in terms of like how my regimen is going to translate. Yeah, it's amazing. And that's what I say to people. Like, you really want to seek out someone who loves to do hair. Oh my God, yes. Loves treating hair because it is a labor of love. It's a lot. Yeah. And, you know, hair is sort of a non-essential organ. Absolutely. If you want to call it an organ of our body. Right? Yeah, it is. And if your body is not working optimally, it's going to sacrifice its hair. That's right. To save other parts. Else. Yeah. Absolutely. Like your heart. That's right. Exactly. So I do tell people, like, it's a byproduct of what's going on internally. Yeah. Absolutely. It's a huge part of it. Yeah. So, you know, us continuing to be physicians have to take care of the person as a human being. Totally. Yeah. And you're seeing a lot of women, right? Like, it's not just hair in men, right? No, a lot of women. A lot of women of African descent, a lot of scarring alopecia. That's most of my practice. Nice. And what do you think about so if we just start off like quick and dirty, like the topical medications, like the good, the bad, what do you think? Because there's a lot of like over-the-counter things you can get. I mean, you know, there are things that are FDA approved like Minoxidil. Yeah. You know, Minoxidil is great. It works fine. It works nice. But I think when you have curly, coily hair, you have to be careful about texture and breakage, right?
Yeah.
Our hair tends to be a lot drier. The minoxidil over the counter is in propylene glycol or propanediol.
Yeah.
It's in an alcohol-y kind of base.
Yeah.
And when you use it on hair like mine, you can get breakage. So, we give certain directions, make sure that your hair is fully moisturized, make sure you apply it just to the skin of the scalp, watch out for breakage, things like that. But I think minoxidil, we're fine. And you have all these companies that have minoxidil combinations. As long as you're getting properly diagnosed before you use that, then I don't have a problem with it. Yeah.
I even tell some patients to use it on their eyebrows.
Me too, with a brush. Yes.
Just don't spread it all around because you will grow some facial hair. Yeah.
Some people are prone to becoming very hairy with topical minoxidil.
And I think eyebrows are just another really important
100%.
Aesthetically. And I love to learn that you did eyebrow transplants.
I do, yeah. Eyebrow transplants are cool. I think with curly, coily hair, you have to be very careful.
Very
careful because,
they could be going everywhere.
They could be going everywhere, yeah. So, you have to use, the gels, lay them down. Some people do lamination, which you have to be careful with.
Yeah.
It's like basically doing a relaxer on your eyebrows. So we want to be careful about, chemicals. Keep them short and then you can lay them down with all the gels that we have. But yeah.
So fun fact, where do you take the hair from for eyebrow transplants?
So it depends on the person, right? So we try to take it from an area of the scalp that has the finest hairs.
Okay.
So we try to take them from the side. Now, I have no fine hairs anywhere on my scalp. I actually had an eyebrow transplant many years ago. And so they just took it from center scalp. But I keep my eyebrows super short.
Yeah.
I use all the gels. Somebody, like I said, with fine hairs on the back, we try to take it from there. In men, you can take it from body hair.
Yeah. So the body hair will transplant as well.
Yeah. Oh, I mean, people, those doctors doing really big cases, 6,000 grafts, which is a whole nother story, 7,000, 8,000 grafts, they add body hair to it in order to, especially if somebody doesn't have enough donor.
That's so interesting.
Yeah.
So the whole concept of hair transplants is that you're taking from a immune privileged site, right? Like the back or the chest.
Right. Or DHT resistant site. Right. And then you're putting it in an area of hair loss. But that's the concept of donor dominance. But there's something called recipient site influence.
Oh, wow.
Yes. Right.
I love how it just rolls off your tongue. Yeah.
So
now we're getting really scientific.
Yes. So the area that you put it in can still thin over time. So you got to make sure you keep up with your medical therapy.
Yeah.
Right.
That's a huge point.
It's huge. Yeah. So you'll put nice grafts in, you'll have a little bit of your own hair. And if you don't keep up with your medical therapy or some sort of regenerative therapy, all you'll have left over in 5 or 10 years are the grafts that you put in.
Yeah.
And you'll be right back at the same.
And that will look
thin.
Very odd. Yeah.
Exactly.
Yeah.
Exactly.
Especially if the hairline's still receding.
Exactly. Yeah. So we want to do both.
Yeah, so that's a really important point, especially if you're doing this medical tourism or something. If there's no good follow-up or consistent medical therapy, A, the investment's going to be wasted, and then B, you're going to need to either transplant again or start from scratch.
Exactly.
And you may run out of donor.
Exactly. So always make sure that you have a good derm that you're following up with who can, listen, we cannot stop people from going and doing the things that they feel like they need to do. All we can do is warn them of the good and the bad. I have a lot of great colleagues overseas who do phenomenal work. So I would only say to just make sure that you do your homework, find the best doctor that you can, and make sure that you're properly diagnosed by a dermatologist here that you can follow up with.
That's really sage advice.
Yeah.
So I get a lot of questions, especially from men, about finasteride, the sexual side effects.
Yeah.
How do you feel about that? There's some studies now coming out.
Yeah, I mean, not only sexual side effects, but potential mental health side effects as well. They're not super duper common. And so with any medication, we have to decide, how long are you willing to take it and what your general ethos is about medications. And because you're the one taking it at home, right? Are you willing to accept some of these? There are lots of patients that you and I both have that take finasteride and they do fine. They have minimal to no side effects. There's been a lot of data about the use of topical finasteride, in a proper base. Maybe combining that with oral minoxidil. People are really afraid of oral finasteride. They can do very well with that. You can also inject a finasteride's cousin, sister, whatever, brother, dutasteride, stepbrother.
More powerful.
More powerful, exactly. Dutasteride in the scalp as well if you're really nervous. That means you have to go to the derm office. You got to go every 3 months. You got to pay money. So so it's about really talking to you about the risks and the benefits. So
that's a good point because we're doing a lot more different deliveries of these drugs.
Exactly.
And then there's new drugs on the horizon.
Sure.
So we have oral minoxidil.
That's right.
Which does grow hair.
It does, yep.
Can cause a little swelling. And,
yep.
Yeah.
But it takes care of one part of the hair loss, right?
Yes.
You're only dealing with the miniaturization part. You're not dealing with all the things that DHT does, right? So,
which is still going on.
Exactly.
So if you don't block the DHT.
Exactly.
And how helpful do you think the DHT blockers like Finasteride or Dutasteride are for women?
They're very helpful. I don't think that we've fully worked out all the reasons why women have hormonal androgenic alopecia. You know, it's multifactorial. You know, depending on the age of the patient, you're going to start out with different medications. You know, we have our spironolactones, which are androgen receptor blockers, which actually also block DHT as well. There's bicalutamide, which in some studies have been shown to actually work even better than spironolactone. But of course, you know, it's a kidney chemotherapeutic medication. You don't use it very lightly, but I think it works phenomenally. There's that for women. And then also if they're postmenopausal, then we think about finasteride and dutasteride.
Yeah. Because if we use it in the premenopausal, it's you can't use it during pregnancy.
Exactly.
So you wouldn't want to get pregnant on these medications.
Exactly.
But it's interesting because the mechanisms of action haven't been fully
In women, no. And also remember, women can have male pattern hair loss as well. Right?
That's true, yeah.
Right. So that's, you go to a derm, they properly evaluate you, and then decide like which medication is going to work better for you.
Yeah. And we even use spironolactone even in patients who've had breast cancer. I know that.
Exactly. Yes, exactly. Yeah. Right.
So we even use that in patients who have like chemotherapy-induced alopecia or hormonal, like endocrine-induced alopecia.
Exactly.
The hormonal blockade.
That's right.
And I even did a trial of PRP in those patients.
Okay.
And we did see good regrowth with just PRP monotherapy, which we wouldn't normally do just monotherapy. But it was just, you know, a really proof of principle study to just show that it's efficacious.
And there have been studies to show that spironolactone is not associated with breast cancer.
Yeah.
So we're good on that. Yeah. And how have you liked PRP? What do you?
I like it. I mean, I think it's great in combination with, you know, topicals and orals. Yeah. Like, I don't just recommend it alone unless the patient only wants it alone.
Sure.
But I do think, you know, combo is always better for hair. Yeah, you need like a multifactorial attack.
Yes.
But it's also painful.
And you have numb?
Yeah, no, I do numb.
Yeah, but the numbing hurts too.
Yeah. Ring blocks, topical,
nerve blocks,
talkesthesia.
Yes.
I can talk a lot. We've done PRP. I'm sure you do it as well. Yeah. But now you're on to exosomes or something like exosomes.
Yes, extracellular.
Talk to us about exosomes.
You know, extracellular vesicles or exosomes is a very controversial topic, right? Like it can come from so many different sources. The data on hair is not amazing, right? So whenever we're talking to patients about any modality, we need to be very upfront with them in terms of like what we see in clinic and what does the data show, right? And so the data on hair is not so great. There are animal studies on the use of exosomes on the dermal papilla and on the hair follicle. But as far as human studies are concerned, there's less than 10, you know? Now, everybody will tell you that exosomes is, you know, the best thing since sliced bread. And it depends on where you get it from. Yeah. You know, plant exosomes, umbilical cord exosomes, placental exosomes. The best one that I ever used was bone marrow mesenchymal derived. The company actually started using, working on COVID. So they were being used as an anti-inflammatory for COVID. So they went into phase 3 trials. So you know it's been rigorously tested. Yeah. All the other ones I think have worked okay, but subpar. So for me, as I always explain to patients, like I do so many things for hair, so many you know, non-surgical therapies. It depends on the cost, you know, what your budget is, your time, because some of them you do once a month, once a week, once every 2 weeks, once every 6 months, right? Some involve needles, some don't involve needles. We have a new device in the office called Trichology. It's in Italian.
Oh, nice.
Yeah. Your people.
Yes. You're welcome.
Exactly, right? So it's probably now one of my most commonly used devices in the office. Okay. So it's a medication active delivery system, much like, you know, your Carolase and all those other things. Oh,
nice. Cool.
And so it uses iontophoresis, which is use of an electric current to drive actives deep into the scalp. That's super popular, so that when you have to come in once. So really, it's about having an extensive conversation with patients, telling them what the studies show, and then what their schedule is and what their budget is.
Yeah, I love that. I mean, you're honest.
Absolutely.
You know, we're not snake oil salespeople. No. Hair is very complex, and it really takes like the patient to be motivated, the doctor to be motivated.
Yes. And patients are always like, oh, I'm so desperate. I'm like, no, don't ever say that to anybody. Don't ever say that to anybody. And also, like, when things are not going to work, you should be told they're not going to work, right? I have, some patients who unfortunately have had just like a ton of procedures. When the follicle is scarred, you're not bringing back a scarred follicle with any of these amazing procedures that you have. You may have to think about doing transplants and decide if you're even a candidate for that.
Yeah.
And when we're dealing with scarring alopecia, it's a little tricky.
It is, yeah.
Yeah.
It's hard. But I love seeing all your results on Instagram. Dr. Osei-Tutu, probably, right?
That's how much
Hair doc.
Something like that.
Yeah. Find her on Instagram. You'll see amazing before and afters.
When you find me, tell me.
Yeah, exactly. But you're also doing Docs for Hair, right?
Yeah, so Docs for Hair, I started this organization. Now I run it with Mina, our friend and colleague, who's an amazing hair transplant surgeon in Kansas. So we actually just hosted our second annual textured hair workshop. So, Mina and I travel all around learning all these like cool techniques, and very often textured hair is not really a topic, whether it be for hair transplant or, non-surgical. And so we've gathered all these techniques because we mainly see these kind of patients. We just teaching derms how to treat these patients with all these techniques that we've learned. So we did everything. We did medical therapy. We talked about non-surgical. So we did nanofat. We did threads. We did PRP. We did microneedling. We did the tattooing of the scalp, and then we did hair transplant. So we did long hair, we did shaved, and then we did a strip, the traditional strip. So we literally covered from head to toe. Literally.
Yeah.
Everything here we did. Yeah.
No, it's so important because it's so much beyond just like male pattern.
Absolutely.
Hair loss, like the hair club for men.
That's right. We're although it's also needed. And
totally. Yeah. But we're way beyond.
We're way beyond.
Yeah.
There's a lot of, like I said, it's a great time to be a hair surgeon. Yeah. Lots of really cool stuff happening.
And I'm excited for what's coming down the pipeline, like new medications that target different pathways.
That's right.
And then potentially maybe hair cloning in the future.
A bit far away.
Yeah.
They're like, it's 5-10 years away. And we're still far. But when that happens, it's going to obviously be a game changer.
Yeah. Okay, cool.
Yeah.
All right. We got to talk about it more then in the future.
Yes, we do. We do. Yes.
Thank you so much for being here.
Welcome. Is this the only way I get to see you?
No.
Okay, next topic.
Yeah, we're going out.
Right. Exactly.
Awesome.
All right.
Thank you. Thanks so much for listening to this episode of Give Good Face. Subscribe on Apple Podcasts, Spotify, YouTube, and wherever you listen to podcasts. And follow along on social at Dr. Anthony Rossi and at Rossi DermMD.